Hello, this is Dr. Lynn McPherson. I am here with Module 4, De-Prescribing in Patients with Advanced Illness, as part of our Continuing Medication Management in Patients with Advanced Illnesses course. I'm joined by my colleagues, Dr. Diana Stewart and Dr. Nicole Brandt. So let's jump in. This is probably a topic you don't hear much about, but a critically important one in my opinion. The objectives are shown here. At the end of this brief presentation, you should be able to list and describe the 5 steps of this de-prescribing process, and given a patient case, determine what risk factors for inappropriate prescribing and adverse drug events are present, thereby calling for a need for de-prescribing. So what the heck is polypharmacy? I know one time I had a pharmacy student who thought that that meant a patient who went to multiple pharmacies. I guess it could be that too, but usually when we talk about polypharmacy, we're talking about a patient who is taking multiple medications at the same time, concurrently, to manage one or multiple coexisting health problems. So I think in the beginning of this program we talked about all the diseases that older adults have, how 3/4 of them have 4 or more comorbid conditions. So it's not unusual to see someone with metabolic syndrome, diabetes, high blood pressure, high cholesterol, maybe some heart failure thrown in just for the heck of it. So people are taking many medications, which is probably why we're living longer. So what do we know? What's the magic number? If we look at how many medications someone is taking, where is the line in the sand that we really increase the risk for a therapeutic misadventure? And that is 5. So someone taking 5 or more prescribed medications that's a huge risk factor for inappropriate prescribing and the risk of adverse effects. I think sometimes we see people taking one medication to counteract the adverse effects of another medication, which could lead to yet another side effect requiring medication therapy. Some additional risk factors for inappropriate prescribing and adverse effects are people who are over 80 years old. They're kind of living on the edge from a functional perspective, and while someone 20 years old might be able to certainly roll with the side effect of a medication much more easily, by the time you're 80 years old, you really are looking for trouble there because you're very much at higher risk. People with cognitive impairment, multiple comorbid conditions, people who abuse illicit drugs, including alcohol, non-adherence to drug therapy. That's an important one. Some people have inappropriate health beliefs where if one tablet works well, maybe 2 would work better. Or maybe I'll just skip this medication because it's expensive or it makes me sleepy. So people who are non-adherent to their drug therapy as prescribed. And certainly when patients have multiple prescribers, physicians, nurse practitioners, physician assistants, it's really important that all the prescribers know all the medications the patient is taking. And minimally, outpatients should use one pharmacy, so at least the pharmacist can assist in making sure that all the medications will play well together in the sandbox. So polypharmacy is absolutely a common occurrence in older adults as the prevalence of chronic disease states increases. So we see, looking at that magic number of 5 medications, 30% of people 65 or older are prescribed 5 or more medications. Dr. Brent, you work in long-term care doing some consulting. What percentage of your patients are taking 5 or more drugs?
It is much higher than 30%. So I'm sitting here chuckling. I'd have to say that probably 80% of our patients are taking 5 or more medications. And you have to remember, in long-term care, anything that's given, whether it's an over-the-counter Docusate, as you mentioned, that's considered a prescribed medication. Because sometimes in these estimates, they don't actually include over-the-counters as prescribed medications, and we know many of our older adults don't tell their medical team about that.
That's right.
So I have to say that I would think that these numbers are much higher than 30%, but definitely in long-term care, it's consistently higher.
And probably also in the eldest old, even in the community. Would you not agree with that also?
Yeah, we've seen actually, various reports in terms of medications. Sometimes that survival of the fittest, sometimes they're not on as much medications when they get above 90 and 95. And part of it might be just kind of lack of goals of care or as you're going to talk about de-prescribing by their team in terms of looking at
And
that.
just to confuse things, 90% of them are a little white pill, right?
Of course they are.
That's right.
Yes.
All right, so some additional risks here. Multiple agents prescribed with the goal of improving morbidity and or mortality. And the risk of adverse effects increases for a variety of reasons. One, physiologic changes of aging. So we know as we get older, we have less lean body mass, more fat. So the way drugs distribute in the bodies, we see altered pharmacokinetics, which is what does the body do to the drug? We absorb it, we distribute it, we may metabolize it, and then we excrete it, usually by the kidneys. As we get older, where renal function, kidney function, starts to decline. So it's harder to get these drugs back out of the body. So if we're not metabolizing and or eliminating these drugs, the serum level or the concentration of the drug will build up in the body, and that can cause side effects. And then you have altered pharmacodynamics, which is the intended purpose of the drug or the pharmacology of the drug. So if the drug is to help you go to sleep, sometimes we see with older adults in particular these changes, such as maybe they'll have an amplified effect. So perhaps it'll make me a little bit sleepy, but somebody 30 years older than me, it would make them sleepy not only that night but all the next day as well. We just saw a patient in clinic on Monday who said, I only take that medication when I desperately need it because I feel like I'm hungover all the next day. So we certainly changed her medication. Rarely we'll see older adults often maybe not have as good a response to drug therapy as we do younger people. So important things we have to keep in mind. We estimate that 1 in 5 medications used in older adults is inappropriate. So if the average patient in long-term care is getting 5 or more, that means that potentially every single patient is taking a medication that could be inappropriate. 1 in 3, particularly minimally, and I would argue it could be even higher, may be inappropriate. And over 50% of nursing home patients with advanced dementia get 1 or more medication with questionable benefit. I even question the drugs for dementia when the people have a very, very advanced state of Alzheimer's dementia. Adverse drug events contribute to several adverse outcomes, such as worsening their overall health status, contributing or causing disability. It can even be a cause of hospitalization. One slide that I'm very fond of using is looking at the 4 drugs or drug categories that land old people in the ER, the emergency room, and that's pretty much drugs that make you bleed, like warfarin or an antiplatelet like aspirin or Plavix, or any medication that lowers your blood sugar, such as insulin, for example. So these are very high-risk drugs in older adults. And, the big payoff here is drug-induced death, and sadly, we do see that as well. And when we look at all these risk factors leading to these adverse outcomes, the number of medications is the top predictor of harm. So we certainly want to look at what I call the Goldilocks approach. Not too few, not too many, just the right number of medications and just the right type of medications. So let's look at this case of Mr. Patel is an 85-year-old man who's been a patient at your pharmacy for many years. He was very healthy when you first met him, but he's now taking 7 prescription medications for multiple chronic conditions. He sees multiple prescribers, including a cardiologist, a nephrologist, and a gastroenterologist. Maybe we can throw in a couple more ologists. What do you think?
Sounds like triplets.
I think it does sound like triplets. Is Mr. Patel at risk for inappropriate prescribing and adverse drug events? We're going to do a straw poll here and see how my expert colleagues vote. What do you say, Dr. Brandt?
Yes.
And Dr. Stewart?
My hand is up for yes as
She's
well.
got both hands up right now. You can't see her, but I'm sitting next to her. So yes, my studio audience is correct. He is at very high risk for an adverse drug event. So how many risk factors does he have? Dr. Stewart, you want to give me 1 or 2 or 3 or 4 or 5?
I'm just going to take a swing at this, and I'm going to guess 4. As I recall, he was taking, I believe, more than 5 medications. The patient is over 80 years of age. He now has multiple chronic conditions, and he was seeing all of those ologists, so he's also seeing multiple prescribers.
So he's just looking for trouble, isn't he?
I think so.
Well, look at that. You are correct. So you hit it right on the head. Totally. All right, so what is this term de-prescribing? Some people don't like this term, but I think it really is a very effective term. It is the process of systematically reducing the doses of or stopping medications, with the goal being to minimize polypharmacy, so to reduce the number of drugs, and importantly, to improve patient outcomes. I don't know about Dr. Brandt, because she's been around the block too, like me, and it's always kind of a kick in the pants when a person says, who's taking 20 drugs, I can't take it anymore, I'm going to stop them all, and you think they're going to drop dead, and what happens, Dr. Brandt?
Sometimes they get a lot better.
Sometimes they get better.
Yeah.
So not a strategy I would advocate for to stop everything suddenly, but sometimes patients just do crazy things. But the goal is not to deny patients effective therapy. The goal is to hone in on the most effective drugs for the patient. So, 5 easy steps, and you can do some awesome de-prescribing. This is from a paper published from a group in Australia, and I love this article because it is such a nice, succinct, systematic way of trying to streamline a patient's medication regimen. Number 1, determine all the medications the patient is currently taking and the indication for each. That's really a 2-part command there. I know when our hospice nurses go to someone's home, they say, "Can I see your medications?" Sometimes patients have to get out their little red radio flyer wagon to wheel all the medications into the living room or the kitchen so the nurse can get a good medication history. So you do want to collect all the medications. Sometimes people forget about the cream or the ointment on their bedside nightstand, or the inhaler that they keep in another room, or the injectable that they keep in the refrigerator. So you want to ask about all the medications. The second is, why is this patient taking this medication? I have to laugh because one time I asked a hospice nurse, "Why is this patient on digoxin?" And she looked at me pityingly and said, "Well, then that's a heart pill." And I had to laugh because obviously I know digoxin is a heart pill because I went to pharmacy school and in fact work at a school of pharmacy. But I said, "Why is this patient on digoxin?" And she said, "I have no idea." That's unacceptable. You have to know why the patient is taking every drug they're taking. How can you decide if the drug is working or not if you don't know what the medication is for? The second step is kind of taking the 30,000-foot view at what is it about this patient I have to worry about, and what is it about their overall medication regimen. So you just heard Dr. Stewart talking about patients over 80 years old, the patient has multiple comorbidities, the patient has multiple prescribers, and then she also talked about the drug issues. The patient is taking 7 medications, and Dr. Brandt will be quick to say, and 5 of those are on the Beers list, which is a list of inappropriate drugs in older adults. So at a 30,000-foot view, there are variables about Mr. Patel, and there are variables about Mr. Patel's medications that really elevate the risk. The third step is to assess the current or future benefit of each drug compared to the current or potential harm. So this is the benefit-burden ratio, and we'll talk more about that. Next is, if you decide to stop medications, generally, I don't like to do more than one thing at a time, because if something goes awry, you won't quite know what to blame. So I like to prioritize. If something's on fire and causing a serious adverse effect right now, that's going to make the top of my list. And then I kind of work my way down. I will also say that it's sometimes very, very challenging to have these conversations with patients, families, caregivers, and prescribers. So sometimes I have to do some tall talking to talk about the benefits and the burdens and why I think it's important to slim down the medication regimen. And your work is not done with step number 4. Probably the most important step is, as you change the medication regimen, you have to closely monitor your patient and make sure you're doing a good thing and not making the situation worse. That's why I advocate for making one change at a time. Some essential components of de-prescribing: shared decision-making. This is where I talked about having those careful conversations. All members of the healthcare team, and I would argue also the patient, the family, and the caregivers that take care of the patient, have to be in on the loop. I know in hospice, often changing the medication regimen, particularly stopping medications, can often be viewed as giving up hope or throwing the baby out with the bathwater, when in fact that is not our intention at all. Informed patient consent, and I already mentioned step 5, very close monitoring. Certainly when we look at drugs that interact, stopping a medication can affect another medication the patient is still taking. So we want to make sure that stopping that drug did not cause a withdrawal symptom by stopping it too quickly, and then also has the disease for which the drug was used become any worse. So every medication, in my opinion, must provide what's called a patient-important benefit. We are using medications that can cause side effects, so if there's not an equivalent and, importantly, a greater benefit for the patient, we have to rethink that. So another important thing is, what are the patient's goals of care? Is it life prolongation? Is it to prevent morbidity? Maybe it's to slow disease progression, prevent decline, or is it a comfort measure? What are the treatment goals for each medication? So many medications that we have our patients take, it's for primary or secondary prevention. For example, a statin to prevent a heart attack or a stroke, to control chronic disease states, maybe to treat an acute disease such as an infection, managing symptoms such as constipation or nausea, which you've already learned about in this course, or managing the side effects from a different drug. Grandma can't sleep, so someone gives her Tylenol PM. All of a sudden, grandma is constipated. So then we give her Senna for her constipation. Now she has abdominal cramping. So you can see where people end up on multiple medications. So here's where it all boils down to: the benefits and the burdens of drug therapy. Are we preventing diseases? As I said, going over all of these things. So what are the benefits? What do we hope to get out of it? What's the WIFM? What's in it for me? To prevent this disease, to control the symptom or disease that I'm having, to treat an acute disease, to manage a symptom. And on the other hand, well, what are the burdens? What are the side effects? What's the burden of taking it? Are there drug interactions? Am I gonna have to sell my house to pay for this medication? Or is it just a giant pain in the neck to take? One example that I like to use are the bisphosphonates for bone health. They are to prevent disease. So if you look at very thin Caucasian women, they are frequently at risk for osteoporosis. I'm sitting here with two very thin Caucasian women right now, so ha ha on them. I see bisphosphonates in their future. But if they were 85 years old, which of course they're not, one of them is considerably younger than that, we have to consider what's the continued benefit. The good news is we know once you've taken these medications for 5 or 6 years, you can stop it, and the benefit will still persist for years into the future. What is the burden of taking these medications? They can be very rough on the gastrointestinal system, and you have to get up early, take them on an empty stomach. I always make fun of it and say you got to drink the blood of a chicken and hang upside down for an hour and a half. It's a very burdensome type drug to take, so you really have to evaluate, is it worth continuing this therapy? Some of the barriers to de-prescribing: the clinical complexity associated with all these multiple comorbid states. Really have to consider the impact of stopping medications. Limited consultation time with prescribers. So often I have to make a very succinct report to a prescriber to pitch my case for slimming down the medication regimen. And as you just heard from all those ologists that we just talked about, often we see fragmented care. We have so many specialists in the loop, you feel like you have to set up a conference call to get the job done. You may not have complete access to information, and in people who have advanced illnesses, often we will see unclear or rapidly changing goals of care. Uncertainty about the benefits or harms if the drug is stopped. I often see medications continued forever and ever due to clinical inertia. And you ask a patient, how long have you been on this drug? Oh, 20 years. Why is that? What do you want it for? I don't know. You call Dr. Smith. Why is Mrs. Jones on this drug? Oh, I don't know. Dr. Johnson started it and then he died, so I just kept it going. So that's clinical inertia. Patient and professional attitudes, and many people are very, very fearful of drug withdrawal. Often I usually recommend tapering down a drug before stopping it, because the patient may be physically dependent on it, and stopping it suddenly could cause some side effects, but also to alleviate this fear of what will happen as we go down on this drug. And often we have no guidance, no evidence-based guidelines to help us with these decisions. You want to prioritize the medications you'll be stopping. Start with the ones for the greatest risk of harm and the lowest benefit first. So the ones that are causing more harm than good should top the hit parade. Other things to consider: ease of discontinuation. For example, if you're going to stop Lasix, you can stop that cold. You don't have to taper the Lasix. And the acceptability to the patient or the caregiver. Certainly there are very strong beliefs about this. Sometimes we'll say to a patient, this preserved vision you're taking for your macular degeneration, it's an enormous pill. And you're a pretty sick little camper here. I would rather focus on your pain and your nausea. What are your thoughts on that? And sometimes they fight like a tiger to keep that medication, but often they'll say, you know what, I would be happy to get rid of that medication because it's enormous to swallow and it's quite a burden for me.
I think we would refer to those as horse pills.
It is a horse pill, you're right. It's as big as a Buick. Multiple studies have evaluated pharmacist-physician-based interactions in a variety of study settings, and the impact of prescribing and the impact on outcome. Not assessed in most studies, but we have seen significant progress with pharmacists working with prescribers in trying to rectify the situation of polypharmacy. Here's a summary of some of the research, which I'm not going to belabor. You can certainly pause the slides and read them for yourself, but we have seen very positive outcomes from this practice. This is an expert panel that identified 5 medications in need of evidence-based de-prescribing guidelines, and I agree. We need better guidance on when and how we should use and not use benzodiazepines. The atypical antipsychotics, I'm sure Dr. Brandt will elaborate on that, but I know I always think of things like quetiapine being used as a sleeping agent.
You got it.
That's a big one. Mm-hmm. The statins, I think I said earlier that I want to die by choking to death on a donut one day when I'm 104 years old. So So I think there comes a certain point in life where also if you've been taking the statins for 5 or 6 or 7 years, if you stop it, that benefit will continue to persist into the future. The tricyclic antidepressants we don't use for depression so much anymore, but we do occasionally use them for neuropathic pain. But we have to be careful because these drugs can alter cardiac conduction, so we have to be careful. And my personal pet peeve are the proton pump inhibitors. And just last week or so, we saw another report coming out from Germany showing that proton pump inhibitors may be linked to dementia. So that certainly piqued the public's interest in that. But I think people get on these medications, the proton pump inhibitors, that are meant to be taken for 2 to 4 weeks, and 3 years later, they're still taking them. Additional drug classes in need of evidence-based guidelines have been identified. Questionable benefits for using them for a very long time. Again, we talked about the bisphosphonates for bone health. Anticonvulsants, that's tricky because it's very scary to stop an anticonvulsant. Wouldn't you say, Dr. Brandt?
It is, especially when you're not always clear what the indication for use. So you get back to that original question, why are you on the divalproex? Is it for seizure? Is it for mood? Is it for maybe neuropsychiatric symptoms such as dementia-related behaviors? Sometimes it's not known.
That's right.
And so one of my philosophies is, as I'm educating the family members, sometimes we don't know until we gradually taper these medications and if there's a reemergence of some of these symptoms.
Yes.
But seizures can be very concerning to families.
Yeah, it's scary to stop them.
It is.
Very. Questionable ongoing need. Beta blockers, antiplatelets. I always worry about the benefits and burdens of antiplatelet. I certainly don't want my mother to have a heart attack or a stroke, but my mother tends to fall a lot, and I don't want her to hit her head and bleed into her head. That's not a good look either. And the cholinesterase inhibitors that we use for dementia, these medications can be somewhat beneficial, but sometimes they can lower the heart rate and increase the risk of falling and pacemaker placement. So it's tough knowing when you have reached that line in the sand. And questionable risk versus benefit. The urinary anticholinergics, certainly the opioids, antidepressants, and the older antipsychotics. So here's a question for you guys. What are considerations in selecting medications for discontinuation as part of the de-prescribing process? What do you guys think? What do you think, Dr. Stewart?
The one that jumps out to me is acceptability to the patient, and I think this one really speaks to the importance of communicating these changes to patients and making sure they understand the rationale behind it. If you walk in the room and say, well, today's your lucky day, we're stopping all of your drugs, you're likely to be met with some level of anger or some unpleasant feeling. But I think all of these are really applicable for de-prescribing.
Yeah, I'm reminded of the patients who say, what do you mean stop my atorvastatin? The heart doctor said to stop this until I die. Are you saying I'm dying today? Well, you better bring your A game there in having those conversations. So you're correct. It is all of the above. So I think this is a really interesting topic, and it's critically important. So here is a link if you would like to learn more about it. And I hope you've enjoyed Module 4 of De-Prescribing, and we will see you in Module 5.